Hi, this is Mike Emmer. We're doing Chapter 12, Psychological Disorders. These are the objectives we'll be covering. I'm not going to read those to you. But remember to open up the PowerPoint to open up the links that are available like these here. How do you know if behavior is normal? As we get started, I really want you to take a look at, be careful not to diagnose yourself or other people as we take a look at mental illness and psychological disorders, because there's a big difference between what's diagnosed as a psychological disorder and what is maybe just quirky behavior or idiosyncrasies. So be careful do not be quick to diagnose yourself or other people after you complete this unit. In ancient times, it was pretty scary. Holes were cut in an ill person's head to let out evil spirits in a process called trephining. Hippocrates believed that mental illness came from an imbalance in one of the body's four humors: the phlegm, the black bile, the blood, and yellow bile. In the Middle Ages, mentally ill were labeled as witches. Also, if you look at over time, we've really had some deplorable ways of taking care of people who are mentally ill. A lot of times they were put in what's called insane asylums. And even in current times, there was a professor who sent his students into a mental institution. They walked in and they said they're hearing voices. But the plan was, as soon as they came in, to no longer exhibit any mental illness and see what happens. And a lot of the students were continued to be treated as mentally ill, even though they did not show any symptoms of mental illness. In treatment, the doctor would say, I'm sorry, but you're not accepting your label, you're in denial. And so it kind of changed the way of how we deal with people in mental health institutions. The professor told the people in the mental health institution that he would send more students there. He never did, but as a result, there were less and less people who were being treated as mentally ill, and they're being more aware of, mental illness is not necessarily a permanent thing for many people. It is treatable. So there you go. Let's take a look at what is abnormal behavior. Basically, the situational context is the social or environmental setting of a person's behavior where there's subjective discomfort. In other words, a person is distressed about the behavior that they're showing. Okay, so the person themselves is distressed about how they're functioning. And then there's maladaptive thinking or behavior, and that's anything that does not allow a person to function within or adapt to the stresses or everyday demands of life. And here's a fun little survey of, are you normal? Remember, a psychological disorder is any pattern of behavior that causes people significant distress and causes them to harm themselves or others, or harm their ability to function in daily life. One of those three things have to occur. So that either one, they're very distressed about their behavior; two, they're hurting themselves or others, or they're not able to function. The biological model says the psychological disorders have biological or medical causes. In other words, there's something wrong with the body. There's chemical, structural, or genetic systems of the body that are not functioning correctly. Psychodynamic model looks at abnormal behavior from repressed conflicts and urges that are fighting to become conscious. In other words, past repressed behavior. Now, behaviorists, on the other hand, they say abnormal behavior is learned, so it could also be unlearned. Cognitive theorists say it has to do with irrational beliefs or illogical patterns of thought. So it's either the body or the behavior or the thoughts. Sociocultural perspective has to do with abnormal behavior is explained by society, because everyone is a product of family, social, and cultural influences. The term cultural relativity means that unique characteristics of a culture in which behavior takes place, what is acceptable in one culture might not be acceptable in another. That's cultural relativity. So what someone might see is mental illness in one culture might not be seen the same in another. It might be acceptable, normal behavior. Cultural syndromes is where disorders are only found in particular cultures. The biopsychosocial model has to do with how we incorporate biology, psychology, and culture into a single explanation of abnormal behavior. So no one operates in a vacuum. It's important to take a look at, social cultural, because they're a product of family, social, and cultural influences, as well as psychological, as well as biological. So the biopsychosocial model incorporates all three. There's something called the DSM-5. It's a Diagnostic and Statistical Manual, 5th edition. It's a manual of psychological disorders and their symptoms. Over the years, it's changed quite a bit. Originally, the DSM-5 looked at homosexuality as a mental illness up until 1972, and of course that's been changed now. But it's something that definitely needs to be looked at. That is a DSM a way of stigmatizing people, or is it a healthy way of diagnosing and defining illness, mental health illnesses? The International Classification of Diseases, the ICD, is an international resource published by the World Health Organization, and it's currently in its 10th edition. There's a nice little video here on the DSM-5. The DSM-5 describes about 250 different psychological disorders. It has grown from only being a handful of disorders on the DSM-1. In a given year, about 26.2% of Americans over the age of 18 suffer from a mental disorder. Only 5.8% suffer from a severe mental disorder. Affected adults commonly suffer from more than one disorder at one time. This chart here takes a look at the yearly occurrence of different psychological disorders. One of the most common is bipolar and depressive disorders. Most people, 6.7% or 15.7 million, have been diagnosed with major depressive disorder. And we're going to go over all these in the next few slides. Now, some issues with these disorders is on the positive side, it provides a common language for all professionals to define what a psychological disorder is. It establishes distinct characteristics or categories of diagnosis for treatment and understanding. On the negative side is overly prejudicial. There's a stigma attached with being labeled a disorder. Sometimes it's hard to get rid of that stigma. Like I mentioned in the psych wards, a lot of people have seen that as permanent diagnosis instead of a temporary. Then there's a psychology student syndrome. Please do not diagnose yourself or other people after taking this course. Next are disorders of anxiety, trauma, and stress. Anxiety disorders are the main symptom is excessive or unrealistic worry or fearfulness. Free-floating anxiety is anxieties that's unrelated to any realistic or known source. Phobias are irrational, persistent fears of an object, situation, or social activity. A social phobia, maybe such as social anxiety disorder, is a fear of interacting with other people or being in social situations that might lead to a negative evaluation. A specific phobia is a fear of objects or specific situations or events. Here's a list of different common phobias and their scientific names. Claustrophobia is a fear of being in small enclosed spaces. Acrophobia is fear of heights. Agoraphobia is a fear of being in a place or situation from which escape is difficult or impossible. Diagnosis requires that one feel anxiety in at least 2 of the 5 situations. Panic disorder is where you have panic attacks that occur frequently enough to cause a person difficulty in adjusting to daily life. A panic attack is a sudden onset of intense panic in which multiple physical symptoms of stress occur, often with feelings that one is dying. Generalized anxiety disorder is excessive anxieties and worries that occur more days than not for at least 6 months. Next are obsessive compulsive disorder. It's intruding recurring thoughts or obsessions that create anxiety that's relieved by performing a repetitive ritualistic behavior or compulsion. A lot of people say, oh yeah, I'm OCD. Please don't use that to refer to your own behavior. It's a lot different when you have a disorder. It's recurring to the point where it's an obsession. It's where you're unable to stop. If you're really into cleaning your dorm, that doesn't make you OCD. If you're washing your hands to the point your hands are bleeding, that's OCD. Acute stress disorder is a disorder resulting from exposure to major traumatic stressors. Symptoms include anxiety, dissociation, recurring nightmares, sleep disturbances, problems in concentration, and moments in which people seem to relive the event in dreams and flashbacks. Symptoms last as long as 1 month after the event. So for instance, if you had a traumatic event, you could suffer from, if you suffer these symptoms, it would be acute stress disorder. If it continues after a month after the event, then it's what's called post-traumatic stress disorder. And these are the symptoms associated with acute stress disorder for more than 1 month. Symptoms of post-traumatic stress may not develop until more than 6 months after the traumatic event. So post-traumatic growth is where people use the experience to drive powerful stories. So it's not always, some good things can come through it as you work through the pain of the past. Some of the events or the symptoms of PTSD are reliving the event, avoiding the situations you associate with the event, excessive psychological arousal, pervasive negative changes in emotion or belief. Oftentimes there's substance abuse, often connected with trauma, which is the self-medicating leading to physical or psychological dependence. Which leads to addictions. Usually addictions have a combination of physical dependence, where you're having a withdrawal symptoms. For instance, if I drink alcohol so much, if I go off of it, my body is actually craving it and experiencing withdrawal from not taking it. So that's physical dependence. Psychological dependence is where your brain is requesting, your brain is craving the high, and that's also self-medicating because of emotional pain that a person may be experiencing. Dual diagnosis means a lot of people with mental illness, let me fix that. A lot of people with mental illness, where did I go? Backspace, there we go. A lot of people with mental illness self-medicate by using alcohol or drugs. And dual diagnosis might be they have an addiction plus they're dealing with a psychological disorder as well. Now, psychodynamic explanations point to repressed urges and desires that are trying to surface, creating anxiety that's controlled by the abnormal behavior. Behaviorists believe that disordered behavior is learned through both positive and negative reinforcement. So if a person has anxiety disorder, it's either by learned behavior with positive and negative reinforcement, or it's because of repressed urges and desires trying to surface. Cognitive psychologists believe that negative, illogical, irrational thought processes lead to anxiety that cause people to have the anxiety. Irrational thinking. These are some things that cognitive behaviorists use to define different types of rational thinking. One is magnification, and that's where you interpret situations as far more dangerous, harmful, important than they really are. Oh, you're making a big deal out of it. All or nothing thinking, and that's where it's going to be either this, or I'm going to fail terribly, or I'm going to be totally successful, but it's going to be nothing in between. That one's performance must be perfect or result in total failure. Overgeneralization, that's interpretation of a single negative event as never-ending pattern of defeat and failure. So in other words, I always fail, I'm always going to fail, I'm never going to be successful. Minimization. It's a tendency to give little or no importance to one's success or positive events and traits. Let's see. biological explanations of anxiety disorders. This is where you have chemical imbalances in the nervous system that causes it may be genetic. There's more activity in the amygdala and limbic system. And then there's what's called cultural variations to the anxiety of disorder. In Latin America, there's the ataque de nervios, which is basically a nervous attack of the nerves, is where it may involve fits of crying, shouting uncontrollably, verbal or physical aggression after a stressful event or loss of a loved one. Choral is a anxiety disorder in China and South Asia, and it's a fear of one's genitals are shrinking. Then Taijin Kyofusho, this is in Japan. It's a fear or anxiety that one will do something in public that is socially inappropriate or embarrassing, such as blushing, sharing, or having an offensive body odor. And this is from Kermeyer, 1991. Next are dissociative disorders. These are disorders in which there is a break in conscious awareness, memory, and a sense of identity, or some combination of the two. Dissociative amnesia is where you have the loss of memory for personal information, either partial or complete. Next is dissociative fugue. It's traveling away from familiar surroundings with amnesia for the trip and possible amnesia for personal information. And then that last one is dissociative identity disorder. And it's a disorder in which an affective person seems to have two or more distinct personalities within one body. You've heard of multiple personality disorder. Shirley Mason, who played Sybil, it was later found out she confessed that her split personality was a ruse. This is hard to prove, but this disorder states that people have to split their personality in order to deal with abusive reality or trauma of the past. Next is depersonalization or derealization disorder. And it's a disorder in which sufferers feel detached and disconnected from themselves, their bodies, and their surroundings. So psychodynamic explanations point to repression of memories, seeing dissociation as a defense mechanism against anxiety. Cognitive and behavioral theorists see dissociative disorder as a kind of avoidance learning. Biological explanations point to a lower than normal activity levels in parts of the brain with people with dissociative disorders. And next is mood disorders. Now these are very common, probably the most common of psychological disorders, and especially with the affect disorder, which deals with emotion or mood. Major depressive disorder is where you have severely depressed mood that comes on suddenly and seems to have no external cause. This may include thoughts of death or suicide. It's most common of the diagnosed disorders of mood. Next is seasonal affective disorder. That's a lot of people that don't get much sunlight during the winter months and they have the body's reaction to low levels of sun. Manic episode is a period of excessive excitement, energy, and elation or irritability. And then bipolar disorder are periods of mood that may range from normal to manic, with or without episodes of depression, or spans of normal mood interspersed with episodes of major depression and episodes of hypomania. Now, a lot of you might say, well, you know what, my teenager has all this. There's a difference between having lots of highs and lows that come with being a teenager. Where depression is where it's continued low mood and thoughts of self-harm. Manic episode might be a long period of excessive excitement, energy, maybe followed with the depression afterwards. But it's a lot more than normal. Most people experience a range of emotions such as sadness, calm contentment, mild elation, and happiness over the course of a day. This is a person's normal wavelength and mood disorder. But with mood disorder, it's like way too high, way too low. Do you see the difference? A person with a mood disorder experiences emotions that are extreme and therefore abnormal. Behavioral theories link depression to learned helplessness. Cognitive theories see depression as a result of distorted illogical thinking. Just change your thinking and they're less likely to be depressed. Biological explanations of mood disorders, they look at function of serotonin, norepinephrine, and dopamine systems in the brain. They also look at genetic origins of them. Next are eating disorders. Anorexia nervosa, that's a condition in which a person reduces eating to the point that his or her body weight is significantly low or less than minimally expected. In adults, this is likely associated with a BMI of less than 18.5. Where there's a refusal to maintain a weight or maintain your BMI that's considered minimally healthy, this has the highest mortality rate than any other psychological disorder. So this one is probably the most dangerous. Next is bulimia nervosa, or bulimia, is a condition by which a person develops a cycle of binging, eating a lot, and then binging, and then purging, which is vomiting, and then using unhealthy methods to avoid weight gain. Binge eating disorder also involves uncontrolled binge eating, but also differs from bulimia primarily in that individuals with binge eating disorder do not purge. Okay. This is not caused by sexual abuse as was seen in the past. It's more often caused by low self-worth, the need to be perfect, falling short of expectations, concerns with other perceptions. A lot of students who struggle with this feel like they don't have a lot of control of things over their life, and so what they control is their eating, which can have very serious consequences. Causes of eating disorders, greatest risk factor appears to be simply being an adolescent or a young adult female. Genetic components appear to be significant also as well. Having strong cultural gender components of what society expects really plays a big part. Body dysmorphia disorder centers on a person's obsession with their physical flaws. Similar to OCD, where you have unwanted thoughts that become obsessions, unneeded physical procedures. People with these disorders often see a distorted image of themselves when they look in the mirror. So culture plays a big part of what, how we're supposed to look, and thus leads to some psychological disorders. Next is sexual dysfunction. The problem with sexual functioning has to do with one of the workings of the sexual act. Either problems with sexual interest, not being interested, or arousal, that'd be physical arousal, or response, which would be the orgasm. Sexual dysfunction can be organic, physical, or psychogenic or psychological. There's disorders of desire, arousal, and then there's physical active, or there's a dysfunction of the physical active intercourse, where you have erectile dysfunctions. You see all these ads on TV. For the female, there would be pelvic pain, penetration disorder, or orgasms, premature ejaculation, or female orgasmic disorder, or delayed ejaculation. I'm not going into detail on those. Next are what causes sexual dysfunction. It could be purely physical, which is treated by drugs. Social cultural factors, in other words, your attitudes towards sex, could affect your performance. Psychological factors such as personality problems, traumatic events, relationship problems. Usually it's a combination of these influences. Next is schizophrenia. It's a severe disorder in which a person suffers from disordered thinking, bizarre behavior, and hallucinations, unable to distinguish between fantasy and reality. If a person is psychotic, that means they've made a break away from the ability to perceive what's real and what's fantasy. And there's a pretty good video here on schizophrenia. Schizophrenia may include delusions or false beliefs held by a person who refuses evidence what they see. Delusions of persecution is like paranoia, where somebody's out to get them. Delusions of reference is where other people, TV characters, or books are talking to them. Delusions of influence, where you believe they're being controlled by external forces like the devil, aliens, or cosmic forces. Delusions of grandeur or grandiosity is believes that they are powerful people who can save the world, or they have a special mission. What I want you to know is that delusional thinking alone does not warrant a diagnosis of schizophrenia. Other symptoms must be present. Okay, next, speech and thought disturbances. A person may make up words, repeat words or sentences repeatedly, or string words together on the basis of sounds, clanging, and experience sudden interruptions in speech or thought. Back to the delusions. If you believe you have a personal mission to change the world, hey, go to it. That does not mean you're schizophrenic. Okay, that's just one of the symptoms of schizophrenia that's held to the extreme. Okay, next is hallucinations. Having false sensory perceptions, such as hearing voices that do not exist. Usually they're auditory and visual, but they can be taste and smell and touch as well, but not as common. Flat affect, this is a person who has a lack of emotional responsiveness. In other words, they just show no emotion. Or they may express emotion that's inappropriate for the place and time. Catatonia is, if a person's catatonic, they're either wildly excessive movements or a total lack thereof. If you want to see a good movie, it's called Patch Adams, and it's about a doctor who really used a different approach to dealing with people in a mental health ward. He treated them as human beings and helped them to interact with each other, even the catatonic people. So it's a good movie. See Patch Adams. Next is positive symptoms. Positive doesn't mean these are good symptoms. In schizophrenia, positive symptoms are abnormal behavior, such as hallucinations, delusions, or distorted behavior, distorted thinking. So it's excesses of normal behavior. Negative symptoms are less than normal behavior or an absence of a normal behavior, like poor attention, flat affect, or poor speech production. Causes of schizophrenia. Biological explanations of schizophrenia focus on dopamine, structural defects in the brain, inflammation, and genetic influences. Here this shows a definite pattern. The greater the degree of genetic relatedness, the higher the risk of schizophrenia in individuals related to each other. The only individual to carry a risk even close to that of identical twins, if they share the same genes, as a person who is a child of two parents with schizophrenia. And this is based on Gautzman's study in 1991. So yes, it's very genetic. It seems to be passed on biologically. However, the stress vulnerability model assumes a biological sensitivity or vulnerability to certain disorders that'll develop under the right conditions of environment or emotional stress. Next is a personality disorder. This is a disorder in which a person adopts a persistent, rigid, or maladaptive pattern of behavior that interferes with normal social interactions. Cluster A, seen as odd or eccentric, paranoid, schizoid, schizotypal. Or cluster B, behavior is dramatic, emotional, erratic, antisocial, borderline, histrionic, narcissistic. Cluster C is the main emotion is anxiety or fearfulness, avoidant, dependent, obsessive, compulsive. Next is the antisocial personality disorder. This is the person who has no morals or conscience and often behaves in an impulsive manner without regard for consequence of that behavior. You've heard of the word psychopath or sociopath. It's where they lack a conscience and they end up in one of two situations, either unable to keep a job and engage in criminal behavior, or they become a clever, charming con artist who make up their way to positions of power. 16% of the incarcerated population probably fit this model. Border personality disorder is where a person has a maladaptive personality pattern in which the person is moody and unstable, lacks a clear sense of identity, and often clings to others. There's also something called the dimensional model. Instead of defining with a range of personality traits or symptoms, they'll chart a person as either neurotic on one side, psychotic on the other, schizoid on one side, antisocial on the other, and use that little chart. Cognitive learning theorists see personality disorders as a set of learned behaviors that has become maladaptive. Bad habits learned early on in life, beliefs and systems of the personality disorder person are seen as illogical. Biological explanations look at genetic factors and stress hormones. Other possible causes of personality disorders may include disturbances in family communications and relationships, childhood abuse, neglect, and overly strict parenting, overprotective parenting, and parental rejection. So there's a lot of different causes for personality disorders. If in doubt, blame your parents. I'm just kidding. Okay, next. A lot of you think test anxiety as a psychological disorder. It's not recognized as a clinical disorder in a DSM-5. So you do not have a psychological disorder if you're worried about taking tests. However, test anxiety has caused countless students considerable stress and anxiety over the years. Determine the reasons you want to do well in the test in the first place. Develop a strategy for controlling your cognitive state and behavior before and during the exam. I always say try to find ways to relax, prepare well, and you'll do fine. That concludes our chapter. Have a great week.